I'm Gina Cooper, co-founder of Loffty Mental Health Assessment, and you're on the Loffty Mental Health Summit. And it is my great pleasure to introduce to you Dr. Dianne Grocott of Reflect Health, who will be sharing her insights into adult ADHD. Dr. Dianne Grocott is a psychiatrist with 30 years experience who has specialized in addiction and ADHD. She has a telepsychiatry practice in Melbourne, mainly seeing people with ADHD and comorbidities or coexisting conditions. Dianne co-founded the Victorian Adult ADHD Interest Group, VARDIG, in 2015, a network of professionals who share expertise and develop resources to help their work with adults with ADHD. Dr. Grocott has been involved in a number of projects aiming to develop best practice treatment of adults with ADHD, training of professionals and educating consumers and the public about the human cost of not treating ADHD and the benefits of doing so. Welcome, Dianne. It's wonderful to have you here with us today.
Thank you very much. And hello to everybody who's listening.
Awesome. Now, you've prepared some slides for us to explain to us what exactly is ADHD.
I have indeed. I spend my days helping people to understand not only what is ADHD, but what it's not. Because most people have heard of hyperactive male children, and the lady who's struggling to manage her high pressure job doesn't think she would have ADHD because she's got not a deficit of attention, she's got too much attention, and that's what is one of the difficulties. So let's just run through some of these things. Here we have a picture of a child in a classroom. Now, this is the 2 millisecond screening questionnaire that I use every day. And I normally see the person with ADHD. I run a clinic for adults, and most of them are looking for a diagnosis or to manage their ADHD better. And I always work with their family as well. So I have the patient, and the patient looks at this and says, yeah, isn't that normal? And their person sitting beside them, who's actually what we call the auxiliary frontal lobe, who's been helping them to manage their life, says no. And actually quite often the partner says, oh, I've got ADHD as well then, or the mum or the dad, because it's a very genetic condition modified by environment. But, you know, if you're born with, say, 20 of whatever, if there are 20 genes and you've got 20 of them, you'll be hyperactive in the womb, you'll be picked up by a paediatrician. And you've got the classic, you know, the stereotype of the hyperactive male child. But if you've maybe only got 15 of the so-called hunter-gatherer novelty-seeking genes, and you've got good structure around you, and you're bright, or you're in an environment where those things are good for you, you may not have difficulties until probably later, when you've lost your structure of high school, you're at university and there seems to be no paths or too many paths, or you've done very well in a job and then you got promoted, and now you're managing other people and you have to be thinking ahead rather than just doing what's happening. And so we often find that people have done pretty well in their life. They've struggled, but they've now crashed. And that's often why they come for a diagnosis as an adult. Or somebody in the family's been diagnosed. People are finding out what ADHD really is. And they go, hang on, but I've got a busy brain too. So that's really the main thing. And the message that we would like everybody to know is that ADHD is a real brain disorder. It's common, 2 to 4% of the adult population, maybe about 5% of the childhood population. It is serious. It's basically, you can't manage your frontal lobe to tell the rest of your brain and your body to do the things you need to do. If the control is intermittent, then things will go wrong. It is a very serious condition. There's a higher level of suicide and lots of other disorders, but it's recognisable and it's very treatable, and there's lots of positives as well. The cost, we know, in Australia 2019 was $20 billion. And if that doesn't make the people who do the funding sit up and go, hey, shouldn't we identify and treat these people? The majority of the cost is actually lost productivity. People can't get a job if they can't run their lives, or they've got a job, but they're sitting there not functioning. And so have a look at the Deloitte's report, which was commissioned by the Australian ADHD Professionals Association and it's on the website, and there's a slide a bit later. Okay, ADHD is not just a mental health problem, it's actually a public health problem, because again, if the main control and the executive function in your life is intermittent, and I'll explain that a little bit later, how it's intermittent. If you can't manage your brain, you can't manage your diabetes or your asthma or your hypertension or your marriage or your finances or your job. So we say, look, if you had diabetes, you would be given education for you and your family and pills and skills. And we think people with ADHD should be given education for them and their family and pills and skills. So what is ADHD? Now, did you have some questions, or do you want me to just keep barreling along?
Yeah, I think people are probably wondering what are the signs and symptoms of ADHD. So I'd love it if you could get stuck in the middle.
Lovely. This is Gina's slide, by the way. and look, a shout out to Gina. She's awesome. And I really appreciate that you've put the seminar together, because all of us are trying to educate the public firstly, because when they know how to manage all sorts of mental illnesses, people will have a better life. And that's what we're all aiming to do. Okay, the take-home message, if this is all you can manage, is ADHD is not deficit. It's dysregulation. Dis means bad and regulation means control of. So it's poor control of attention, movement and impulses. Well, we've sort of figured that, but also emotions. And the emotional poor control is something that causes probably the most grief and cost. Anyway, so the first symptom on the list is and it's not inattention. If you're a hyperactive male child, yes, it will be inattention from the outside. But if you look inside and the person grows up and says, I just can't control my attention, either I've got too much or too little, and sometimes it's quite normal. So you'll have an adult who's easily distracted, can't concentrate, can't pay attention, unless they're really interested, or they're frightened, or they're doing something they're good at, in which case they may be actually better than other people. Then there's hyperactivity, which again is dysregulation of movement. So there's this constant wanting to sort of smack yourself to wake yourself up on a long country drive. That's the same thing. The brain is going to sleep and the body's trying to do stuff, and produces adrenaline from movement as well as from other areas. And so this person is constantly fidgeting and drives other people nuts. So they're told sit still and concentrate. And the poor kid is in a double bind, because if they sit still, they can't concentrate. If they concentrate, they can't sit still. But they're also in a trap, because the people who love them and care for them and say, here's help, they are above them and they say this is help, but that help doesn't work very often, and often it's painful. But the bottom of the cell, I usually say, is the fact that the person sees this is truth sometimes. Sometimes they can try harder and sit still and concentrate. So they're in this trap, which I call child abuse. I am short-sighted, as you can see. I wear glasses. In about year 9 at school, I couldn't see the blackboard, so I migrated down to the front of the maths class. And eventually they realised I just needed a pair of glasses. But they didn't say, oh, Dianne, you've got this genetic condition of short-sightedness, which is actually long eyeballs. The picture doesn't go on the retina. So I've got actual dysregulation of my vision. Up close, I'm actually really good. I can squint or try harder to get the middle distance. Jenny, you're blurry at the moment. But they didn't say to me, well, Dianne needs to try harder to see, and she has potential to go to medicine if only she could see, or patronise me in the school reports. She's done much better this term. She was more able to see and she could do well in life. But the point is, a kid who has dysregulation of their attention, of their mind's eye, they can do something that's now. They can try harder to do something that's sort of soon, but something that's in the future, unless it's really made concrete, they cannot do it. But they're constantly exhausted and they try their hardest and then they get exhausted. And so then you get the oppositional defiance disorder, and you get the overwhelm and the anxiety, the depression. And people find ways of getting a good feeling. Could be running away, could be attacking, or getting addicted to something. So that's really ADHD in a nutshell, and we've only got to symptom 2. Let's go to symptom 3, which is impulsivity. Okay, people interrupt because they care, because they are in overload. There's so much happening in their brains and they really want to answer the question, but they heard the first few words and they know, and if the tone of voice is there, they know they're in trouble. They just want to get it over and done with, so they interrupt, but the person wants to say the whole sentence. So there's a lot of things go wrong. one of the other questions I ask about is road rage, or how are you at waiting? Or are you restless all the time? Or do you keep busy so you don't feel restless? So you're generating your adrenaline. So we start to ask these questions and people go, oh, yeah, is that ADHD? Then you've got emotional dysregulation. And that is the difficulty, because this part of the brain which controls everything else has, if they have trouble with working out what things to think about and movements and impulsivity, they also are going to have trouble with emotions. And usually I say to people, your friends don't mind if you're away with the fairies, because as an adult, you're going to be looking at them and you're listening and you're many other channels in your head, but you can keep the conversation going. They don't mind if you're wriggling and jiggling, and often your wriggling and jiggling is going to be socially appropriate. Adults don't do this. They do socially appropriate grooming, and they twiddle and they hide the things behind their back, or they doodle or they sing or whatever. But so your friends don't mind the movement. They also don't mind if you interrupt, because you're usually funny, and the best stand-up comics have ADHD. But they do not like it if you behave like a toddler when you're meant to be a grown-up. And you don't like it. So you then get frightened of yourself, which causes shame and guilt and a whole lot of rejection sensitivity sort of things. So this is really a difficult thing for people to understand. And the big question is, why isn't it on the list? The point is, emotional dysregulation is so common with other things that we're really only looking at what is ADHD separate from other things. So we'll get onto that when we see my iceberg later. But first of all, I just want to show you the most beautiful little picture. Again, take-home message, your frontal lobe runs the rest of your body. People with ADHD, the messages are intermittently getting through, so they've got intermittent grip on the things they want to. So again, you can understand, if life is easy and they're doing something they're good at, well, they don't need a big, strong grip. But if they're in overload, or they're drunk, or they're anxious, or in pain, or they're out of their depth, and they're in overload, they're more likely to lose their grip. So it looks as if they've totally lost it. And they then ask themselves when they calm down, why wasn't I behaving normally? So there's a lot of fear and confusion that they live with, which makes it worse. Okay, diagnosis is pretty much deciding, what are we looking at here? And then we can make some ideas about what we might do about it. But let's just say, if we wanted to diagnose the type of big cat you've got here, you can have a lion or a tiger. The lion's got a mane, the tiger's got stripes, so you can put the label on them. But it doesn't tell you anything about the teeth and claws, which is common to both of them. And that's the emotional dysregulation, I think, in the ADHD picture, because lots of people have lots of different disorders have the emotional dysregulation. But in ADHD, it's very, very difficult to manage. And the other one you want to know about is, how do you tame or feed this particular big cat? So when I'm looking at diagnosis, it's really, how do I help this person have a better life? So the list there is the DSM-5, symptoms present before at least the age of 12, symptoms that have significant functional impact. Lots of people say, oh, I've got a bit of this, that, or the other. I say, well, look, is it a disorder? Is it significantly impairing your life, not just in one area, but all over the place, because you're carrying this busy brain and poor regulation of yourself? And on the list of inattention symptoms, if you score 5 or more as an adult, or 6 or more as a kid, you get the tick. And I have patients, they go, hey, you're 9 out of 9, high five. They go, oh, I haven't scored so highly for a long time. On the hyperactivity impulsivity list, you've got, again, 9 symptoms, which are very much ADHD, busy brain, and busy, can't control things. And if you score 5 or more as an adult, or 6 or more as a kid, then you get the the seal of and if you've got both lists, you get combined. And we talk about the presentation because it changes. A person can look perfectly ordered in a place where they're doing well. So you might say, well, there's no disorder at the moment. And what we're aiming to do is get to the person who still has a busy brain, but they're managing their life so it looks as if they're not disorder, they have a good function. Now, going back to, I think I had this one. Yeah, there is a quick screening questionnaire, and that is, the people have probably come across the ASRS. You can look that up, the Adult Self-Report Screening Scale for DSM-4, which has the 18 questions all mixed up, so you can't, can't cheat. And then what they did for the DSM-5, and to make it quicker, they took the top 4, which are the difficulty concentrating on other people, even when they're talking to you, because you're so busy thinking of other things. Difficulty leaving your seat in meetings. Well, sometimes people have forced themselves to sit, but they're so busy forcing themselves they haven't heard a thing. So I would still say, well, that's a symptom. Difficulty unwinding and relaxing. And some people say, well, I don't. Well, if you have trouble when you could, that may be a symptom as well. And in a conversation, do you interrupt people and finish their sentences? They're the 4 actual symptoms. But then they asked a whole lot of adults with ADHD, what else troubles you? And they came up with the big 2, which are the putting things off, the avoidance, the procrastination. They have to wait till they get a bit of a run-up of adrenaline and fear and deadline, and then bang, they pull an all-nighter and they're brilliant. So they may be functioning well, but they're exhausted doing it. And they don't like themselves because they can't really plan. And they just don't have that control. They have to wait till it sort of comes upon them. And the 6th one is depending on others to get your life in order. Now, I've met some people with raging ADHD who have the most amazingly ordered lives. They may be even very obsessional, but they still have this problem because they're doing things out of fear, not out of choice. So again, the limitations of any screening questionnaire is it just points to the fact that, yep, I'd say if someone scores very low and they know what they're looking for, then they probably haven't got ADHD. When I am aiming to diagnose somebody, I say, well, the tip of the iceberg is, the teeth and claws, the mane and the stripes. It tells one thing from another, and these are inattention, hyperactivity, and possibly helpful. But it's the underneath of the waterline of the iceberg which causes the difficulty. Busy brain, emotional dysregulation, anxiety, addictions, avoidance, isolation, loss and grief, shame, and some skills. Sometimes they're good, sometimes they're not. So as I said, I flash up that picture of the child in the classroom and it's a 2 millisecond, do I have it? Yeah, you've got it. So what? What are we going to do about it? And how can we help you manage your life? And really, the issue is ADHD is often a spot diagnosis, but it's working out what are the comorbidities and how can we manage them. And I wanted to talk a bit about Loffty. So Loffty being a screening questionnaire is really useful. Now, I've been a fan of Loffty for a long time, and I looked at it and thought, can I use that in my psychiatric practice? And came to the conclusion that I don't need to use this screening questionnaire because I am doing this plus a whole lot more. But I really appreciate it when the GP sends the patient along and says, listen, I wasn't sure what was happening. I've done a Loffty and they've got ADHD and they've got depression and there's something or other else and there's some substance use and there's other things they probably haven't told them. So I think the place of Loffty in ADHD, apart from the fact that it's really easy for ADHD people to do, they're not overwhelmed and they can't go back 16 questions, it's one or the other. I think that's really helpful. And I gather that you're going to be enabling the public to use that. And I think that's really helpful because with ADHD, there's so much confusion that if a person's actually got an official score, and often they go on the websites and they look at the ASRS or the Jasper Goldberg and some other ADHD only rating scales, they then come up with, I think I've got this, and therefore I do need to go and do something else with it. So it's really helpful for the person to validate that there is something wrong that's not just in their own imagination. And so that's a validation, but it also helps the GP or maybe the psychologist to get a better picture. At the moment, they still need to be sent to a psychiatrist for the actual diagnosis, and I'll hop on that soapbox later and talk about why I think GPs ought to be enabled and trained to do that as well. But I think it's really helpful because then we've got a clear picture, and then they see the psychiatrist and we help them to see not only what other things they've got, but again, what we're going to do about that. So did you have other questions about where I think the use of Loffty might be helpful?
I think that's pretty good. I think, yeah, as you say, people can log on to the website and if they suspect that they might have ADHD, listening to some of these signs and symptoms, they can do a thorough, comprehensive assessment, and it will screen for 30 different mental health conditions, including ADHD, adult ADHD. And yeah, then that will give them an instant report as to, whether it's likely, possible, or probable that they have ADHD. So that's an assessment that they can then opt they have the option of sharing it with their GP.
Yeah.
They can use that report as, a conversation piece. It helps really voice their symptoms and their challenges with the GP, and they can use it as the start of a better informed discussion about what challenges they're facing. And as you say, the GP can then share that with the psychologist or the psychiatrist. So yeah, that's pretty much it.
I don't know the much about how things work in New Zealand, but in Australia some years ago, stimulant medication, dexamphetamine particularly, was splashed around a lot, and a lot of it was ending up in the wrong places, so the government wanted to ban it. And then the paediatricians said, hey, but we need this for our kids with ADHD. By the way, a stimulant medication doesn't stimulate ADHD people. It calms their brains down and makes them able to focus. The neurologist said, we need this for people with sleep disorders, particularly narcolepsy. And then they said, well, when the ADHD kids have are older, they don't see the peds anymore. Suddenly they don't have the disorder. You don't blow out your 18th birthday candles. It's the only disorder I know that is time sensitive like that. No, they would often get missed. But if they do go and see a psychiatrist, the psychiatrist will need to prescribe. So the government actually said only a neurologist, psychiatrist or paediatrician can prescribe. So that took out the GPs from the equation. GPs then were de-skilled. They don't know a lot about this because they're not prescribing the medication. So people will go along to their GP and say, I've probably know more about ADHD than you do because you're not treating it, or you don't think you're treating it. And so if a person comes along and they've got some evidence of this could be what I've got, then the GP is more likely to say, oh, okay, well, I might refer you to a psychiatrist for further information, can send off the Loffty, even if the GP knows nothing. Now, on my soapbox, we are working on a GP training program. And what we're aiming to do is have GPs who have enough information to be able to at least see and screen ADHD and not just say to the patient, no, you're not wobbling around, so therefore you haven't got it. But also GPs who want to take the step further and get further training. We are hoping that eventually they'll be allowed to get the permits for ADHD medication in their own right. And that will just open things up. I think if you have diabetes and you have to wait 3 to 6 months to see an endocrinologist before you can get your script for insulin so your brain will work, that's appalling. That would be an outrage. But it happens in ADHD. So as I say to all the people listening, write to your politicians, make a noise, because if you don't, it will continue in the very sad way that it's going. So a little bit more about what ADHD looks like, adult ADHD. Right, well, you can imagine, if you know the biology, what you're going to be finding. You've got this brain that's not able to focus. And so they're in overload. They forget things, or they write lists, or they lose their lists. And there's poor time management because time is in the frontal lobe, and it's a concept. Abstract concepts don't go very well until they're concrete. They take on too much. They're disorganized. They repeatedly underachieve. They might get bored and they change jobs or relationships or hobbies or all sorts of different things. Or they get sometimes stuck in quite bad relationships, or they're frightened to be promoted because they know they're likely to fail. So there's lots of fear, and there's lots of just loss of potential and giving up. Here's another list: they crash and burn, they have depression, they interrupt, they forget to pay their bills and their traffic fines, and their difficulty concentrating, except unless it's interesting and then they're brilliant. Some of them can't even sit and watch a movie, which is really devastating. What does it feel like? Well, they have normal range of feeling, unless there's another disorder like depression on top, but it's normal. It's poorly controlled. So they might have all of these feelings in the first 20 minutes. And that's, again, what we're looking at, poor control. They do come along with friends. ADHD people have lots of friends, lots of comorbidities, sleep problems, anxiety, depression. There's an overlap with the bipolar disorder genes as well. But often they have a mood, just instability. And often we pop in a tiny dose of a mood stabilizer before we use the ADHD medication, not diagnosing bipolar, but it's like the trainer wheels, it sort of stops them wobbling. There's quite an overlap with autism spectrum disorder. Substance use is high on the list. Some research in Australia showed about 40% of people seeking treatment for drug or alcohol problems had ADHD undiagnosed. And then, of course, the people in jail, around about 20 to 30% of people have ADHD undiagnosed. and some diagnosed, but they're not allowed to use the medication in the prisons because the short-acting one is abusable. There is a new long-acting one which they've used in prisons very successfully in England, and they say we have less riots. So we reckon there should be a ADHD training courses with a long-acting medication in prisons in Australia and New Zealand, which would really make a difference. Again, trauma. If you're constantly told to sit still and concentrate and you can't, you don't like yourself and you're more easily traumatized. And there's a whole lot of other medical disorders that seem to have friends with ADHD, particularly if your gut isn't working and you're letting rubbish into your system and you've got a chronic inflammatory process. Well, that makes it harder for your brain to work, because the question is, where do I get my brain chemicals? Well, from your food, your vitamins, and also from your gut bacteria. So moving along, let's just talk a little bit about the synapses. Most people have probably heard that word. Syn means together, like sync your phone, or synergy, and apps means fasten. And the synapses are the parts of the brain where one brain cell talks to another brain cell. You've got 100 billion of the little brain cells, they're like computers. And the way it works is, if you just follow the picture, we're going from the purple. The dopamine is the chemical that I'm going to talk about in a moment, but little dopamine, the little black diamonds, and they sit around in little bags waiting to be thrown across to the other brain cell on the other side of this gap to send the message. And what happens is, if they get thrown across and they pop into the little, like a basketball in a hoop, in the receptor on the other side, something goes twiddle and ping and the message goes on. And then they get recycled up these little vacuum cleaners. They're called the dopamine transport pumps. And then they sit in their bags, and then the next message comes. And this is actually the way the brain talks to itself. And the other different, they're called neurotransmitters, which is neuro is brain cell or nerve, transmitter is messenger, and they're different shapes. So there's adrenaline and serotonin and histamine and dopamine, whole lot of things. They're just different shapes. So they're sitting, waiting, send the message and bounce back again. Now, it may surprise people that ADHD, attention deficit hyperactivity disorder, is actually excess of these little dopamine transport pumps. So they've got too many of the transport pumps, and that's genetic. So let's imagine what would happen if we've got too many of the recycling pumps on the ascending side. You can still get messages across, but if you've got too many little vacuum cleaners, they suck up the messages too quickly, so the messages are going to be weak. But if you try harder and somehow create dopamine and adrenaline, there's the other part, you create extra of these things, or push, 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 you're going to get your messages through normally. So that accounts for the intermittentness. Medication for ADHD blocks these transport pumps, and then you get normal messages without having to try so hard. And illicit drugs, stimulant things that you can buy on the street, they do this medicinal thing by blocking the pumps and actually have a very nice medical effect. But they damage the little hoops receptors on the other side, cause brain damage and addiction. So psychiatry, as I always say, plays in the synapses. We've been doing this for a number of years, and all of my medications are like a bunch of keys that will plug various things. And depending on what I want to do with the patient, we put in the medication and it'll be plugging or unplugging different things. Things that affect the receptor side cause addiction. And we know that the alcohol and benzodiazepines can become, a person can become dependent because these little receptors can change. And the addictive drugs you get on the street cause brain damage. But I've got many people who are using something nasty for the medicinal thing, get them onto a ADHD medication. They give up their drug use. They don't want it and they don't need it. Nobody wakes up in the morning and says, I'd like to be a drug addict. I think that's probably what Ed Ogden said as well. Okay, so if you've got the message that it's a biological thing, you can fix it biologically. Medication does the right thing. Stay off the nasty drugs. But you can also do things to do with increasing your dopamine and your adrenaline. So let's find out a little bit more about these chemicals. Here's another picture, and I talk to people with ADHD all the time who can take in pictures where they can't necessarily take in lots of information. And in fact, we're all like that, but ADHD doubly so because they're busy. So imagine your brain is a radio and it's not quite tuned to the station. So you're playing 16 channels and a little bit of static as well. What can you do? Well, if you increase the tuning, increase the volume, that's adrenaline. What adrenaline does in the brain is increases the loudness of signals. And it doesn't matter which signal it is, it's going to make everything louder. It's the fight, fright, and flight chemical. Look for danger. There's tigers. And when you find danger, you scan. And then when you find it, you magnify it up. So the magnification is important for survival. So what you can do is, if you've got 16 channels playing, is you can make everything louder, and then you can probably find the channel you want, but you might get into overload. And that's why people with ADHD, they're adrenaline junkies, jumping out of perfectly good planes, and they sometimes do really well in a crisis. And if they scream or shout, they do better. And yes, the children actually do study better with loud music, mum and dad. If your kid needs loud music to study, maybe they're trying to tune out stuff in their head. Now, you could use serotonin. This is the mute button. Serotonin is like putting a blanket over everything, so you're not so bothered by the fact that you can't hear the thing. And generally, people with ADHD get depressed because they find themselves in a mess, and they go to the doctor and say, "I'm depressed." And the first line treatment for most depression is a serotonin blocker, so it blocks the little serotonin vacuum cleaners, and you get a stronger serotonin messages. But that makes an ADHD person worse. So then they go back to the doctor and say, "I'm really, really depressed. Oh, let's bump the dose up." And by the time that the drug is 4 times the starting dose, the person goes, "I'm feeling really good." When you've flooded your little synapses with so much of this particular chemical, it's not only plugging serotonin, it's plugging adrenaline and dopamine, and you're treating the ADHD. But often you've got too much of the serotonin. So I see lots of people who said, "Oh, I've tried antidepressants and I felt awful." I said, yeah, because you didn't need a serotonin increase, you needed a dopamine and noradrenaline. Dopamine is the best friend of somebody with ADHD because it actually is the tuning knob. Just that one song can be heard and everything else sits down. What dopamine does is it increases signal. So if you've got a wood with a lot of trees and you can get one tree standing out and all the rest sit back and behave, that's a dopamine effect. It's also a 3D effect. And the sense of being able to see now and later, or this is important and everything else can settle down, are dopamine effects. You also get dopamine when...
Prioritization, do you mean? Prioritization of things.
I like that. Oh, you said as well.
Yeah.
Being able to prioritize. Well, that's the job of the executive function in the brain here. So the big question to anybody with ADHD is, so why do you sometimes function normally? Well, if you've got enough dopamine and noradrenaline in your synapses, in your frontal lobe, which controls everything else, you're going to be absolutely normal. And they are. So that's why I say it's dysregulation. Their attention is mostly normal. Sometimes it's too high or hyperfunction. Sometimes that's brilliant. And sometimes it's too low. Just with diabetes, you haven't got lack of blood sugar. You've got blood sugar that you can't control. Sometimes it's too high or too low. Or me with my glasses, I haven't got lack of vision. I basically have not enough here and sometimes too good. So it's a lack of control of, which means it's intermittent. It also means you can do something about it, and it's not just pills. So it's education of the patient and family, and pills and skills. So having a look at these things, I get my people to go, "Oh yeah, I am normal a lot. Yeah, I do use these things." And then what we do is we work out what sort of compensatory strategies. Oh, I keep busy all the time, or I actually have learned to keep my place decluttered, so I've only got 1 or 2 things to worry about, or I've learned to make choices. If you've got 16 things to choose between, you just get into overload. If you do that little, the Wimbledon thing where you go, first and second seed play each other, chuck that one out, next one, chuck that one, and you've got these left, you go to the second round and we do this. So we teach people decision making so that they can cope and declutter their head. But people say, "Oh, is that why I do X?" Yeah, you're chasing dopamine and adrenaline. And when you've got enough, then you're functioning well. And the aim is to function within the good zone. So that's probably And there's lots of hope. And as I said here, stimulant medication is part of the toolkit. Stimulant drugs you can buy on the street is often part too many people's toolkit, and we would like them to know that, because sometimes they say, I hate this stuff, but I can't function without it. I had one lady who said, yes, she was so ashamed. I do buy it, you know, from those people once a fortnight, and I divide it into 7 amounts. That's for parent-teacher interview, that's for going to the bank, that's for cleaning up my house, and that's for doing my shopping. She's not addicted to the stuff, she's using it medicinally, but there was all the horrible things. And so we got her into some medication, and she hasn't touched that drug for years, and she's so grateful. So I think that's the other word, is that ADHD substance use. The international guidelines say screen every person with a drug or alcohol problem for ADHD, and screen everybody with ADHD for a drug and alcohol problem. A little bit more about the medications. Another picture, imagine your brain is like, you've got a teacher in the front who is in a classroom of children. That's called the limbic system, which we don't have time to go into. It's fascinating. This is your classroom. The kids are all doing their stuff. They've got no idea of the future. They can't see what's going to happen if they don't do their maths and they, you know, fail their exams. But the teacher has the overall picture. The frontal lobe, or the teacher, has 2 perspectives and can see 2 things without having to kill off one. Down there in the classroom, they're doing one thing or another thing or another thing. There's lots of stuff happening, but they haven't got the big picture. So the frontal lobe is the big picture, and you need to see the big picture in order to make choices and say no to this or prioritize. So the frontal lobe has this ability to say, open your maths books and put the rest of the stuff away. The dopamine effect. And as we know, you've got too many dopamine transport pumps. And let me say, that's not the full picture, but it's true, but it's a useful way of, I've got too many vacuum cleaners in my frontal lobe. So the teacher, it's like the teacher has laryngitis, can get the messages through if the teacher pushes hard and tries hard, but can get it exhausted. And so will look like a good teacher if the class knows what they're doing. You can teach well with laryngitis if the kids are trained. But if you're trying to teach them something new, it's not going to work. Or if it's a hot, windy day on a Wednesday afternoon, doesn't matter. Okay, so intermittent messages from the teacher to the classroom. So what do? Medication increases the messages. So it's like the 2 stimulants, dexamphetamine and methylphenidate, which is also called Ritalin. They're like a little megaphone for the teacher. So, you know, teacher can talk in and the message gets through. There's another one, Strattera or atomoxetine, which sort of helps with the laryngitis, but it takes a long time to work. And then there's another one, which is like a little teacher's aid, sits down and calms down the class, so then you don't need as much of the stimulant thing. So there's a number of medications, plus we treat every other thing in parallel if we need to. So from this, I'm hoping that you've got an idea that ADHD is not as awful as people thought it was, very treatable, extremely easy to diagnose, but to treat it well, to manage it well, you do need help, quite a bit of help. And there's a lot of help available on websites, the ADHD New Zealand, ADHD Australia, Australian ADHD Professionals Association, AMOB in Melbourne, the support group is ADHD United. What is difficult is actually finding a psychiatrist, because we've all closed our books. So we're hoping the GP training program will come soon. We are training psychiatrists, more psychiatrists are wanting to know about this. So it is improving. But at the moment, it's a tough thing. So, you know, while you're waiting to get in to see a psychiatrist to get the medication, you do all the other things. Is, you know, educate yourself and get to the point of you're managing your ADHD, because you're managing your dopamine and your adrenaline in your life. You're managing your brain, and then you'll have a wonderful life. And I think, Gina, we've got another talk on management coming up.
Yes, we do. Oh, that's been so awesome. I love all the metaphors that you've shared, particularly the, you know, give the teacher a megaphone to get that message strong to the rest of the brain. That's a really simple one for people to remember. And yeah, that's just wonderful, saying all the different signs and symptoms. People might start thinking, you know, is this me? Encourage people to reach out to some of these organizations, these support groups, connect with other people with ADHD, learn about it. To get an assessment, go and see a GP, take that assessment and for a discussion with your GP, and try to get into a good psychiatrist as well. So yeah, there's so much gold in there today, and I hope people have been taking notes and they can rewind this and have another listen if they need to. But yeah, next coming up, we are going to be discussing how to manage all of this. So coming up with a management plan for yourself. So if you've got the all access pass, you can dive into that with us in a moment. And just wanted to thank you, Dianne, for all your hard work and your dedication to educating people about ADHD and to helping ADHDers. I really appreciate it, and thank you so much for your work.
Sure, lovely. Thank you very much, Gina. Bye bye.